We're all set. All set whenever you are.
Okay, thanks, Craig. So good morning, everyone, and welcome to the Maryland Insurance Administration's virtual public hearing on the 2024 proposed health insurance rate filings. My name is Kathleen Borain, and I serve as the Maryland Insurance Commissioner. The purpose of today's hearing is to discuss the 2024 Affordable Care Act health insurance rate filings submitted by those Maryland insurers participating in the individual non-Medigap and small group markets. Those are filings that are before the Maryland Insurance Administration for consideration. And here with me today from the Insurance Administration are Brad Boban, our Chief Actuary, Adam Zimmerman, Senior Actuary, Henry Nokoma, Senior Actuary, David Cooney, the Associate Commissioner for Life and Health, and Craig I, who is the Chief for Communications and Public Engagement. This year's hearing is on the Zoom webinar platform. The hearing is being recorded and will be posted to the MIA's website along with any of the materials submitted. So in a few minutes, our Chief Actuary, Mr. Boban, is going to give us a high-level summary of the filings, together with an overview of key considerations in the administration's review of those filings. We will then hear from each insurer that has submitted filings. Representatives of each carrier will have the opportunity to explain their filings and the changes sought, and the MIA will ask questions about the filings. Next, we will take comments from interested parties. We will first hear from those who signed up to speak in advance. I appreciate that some of you joining us today may not have had the opportunity to sign up to speak in advance, but we would still like to hear from you today if time and technology permit. If you look on your screen at the bottom, you will see the chat option. If you want to share your views, please type your name and your affiliation into that chat with the phrase, "I wish to comment." And then as we move through the agenda, when it's your turn to speak, Mr. I will give you access and bring you over into the speaker's portion. If you're unable to access that function or you're joining us by phone, you can still provide your comments by forwarding them to the administration. We will provide a slide at the end with the contact information. The contact information is also available on our website, insurance.maryland.gov. So just to step back for a second, in May, carriers submitted their rate filings containing the proposed 2024 premium rates for Affordable Care Act products. Those filings impact about 471,000 Marylanders. The requested increases are reviewed by the Insurance Administration, and all rates must be approved before they can be used. Before approval, all filings undergo a comprehensive review of the carrier's analysis and the assumptions that underlie the rate changes they're asking for. Before that approval, and that is an iterative process that occurs between the actuaries for the companies and the actuaries at the Insurance Administration led by Mr. Boban. Public comments are an important part of the review process, and we take those comments into consideration when we make our final determination. More information about the review process can be found on the MIA's website, which I just mentioned, insurance.maryland.gov, and we expect that we will have public announcements of the approved health insurance rates no later than Friday, September 15th of this year. So again, at a high level, in the individual market, carriers have requested an overall average rate change of an increase of 5.7%, with the average request by carrier ranging from -2% to +8%. And in the small group market, which is utilized by employers with 50 full-time equivalent employees or less, carriers in their May filings requested an overall average rate increase of about 7.5%, with the ranges going from a 1.4% to a 20.4%, depending on the carrier. So the overall average rate increases being requested for 2024 are lower than the requests received last year, driven primarily by claims for 2022 coming in lower than anticipated, and a reduction in the projected claims trend. And now I'm really going to turn it over to our Chief Actuary, Brad Boban, who can go a little bit deeper into that and provide an overview of what he is seeing and a deeper dive into our review process. Brad, let me kick it over to you.
Thank you, Commissioner. I'm Brad Boban. I'm the Chief Actuary. Craig, are you able to put up my PowerPoint slides, please? Great, thank you. If you could please go to the next slide. Starting with the individual market, as the commissioner just said, it's an average of 5.7%. As a reminder, last year carriers initially asked for an 11% increase. What we ended up approving last year was a 6.6%, and that was after the attachment point was lowered from $20,000 to $18,500 because of the uncertainty with the ARPA subsidies being extended at the federal level. And so, this 5.7% initial increase request is lower than what we approved last year. In addition to the increases being filed, we have rates from a new carrier, Aetna. They have filed rates that are going to be available in all counties in Maryland. So consumers will have the choice of at least 3 carriers now in all counties. And that's a big change from before the reinsurance program started, when rural counties only had a single carrier, CareFirst, operating in them. If this 5.7% increase were to be approved, it would result in 2024 rates that are 21% lower than the 2018 rates on an absolute dollar value. Once again, that's due to the reinsurance program. There were 3 years of double-digit rate increases that drove the rates down almost 35% when the reinsurance program was initially implemented. And then since then, rates have started to increase at a low single-digit level. With the filing data that we've gotten from the carriers, we've seen the total market enrollment has dropped slightly between 2022 and 2023 through April, a 1.6% drop. This is the first enrollment drop since 2018. We've had multiple years of strong double-digit growth. Overall enrollment is up about 17.5% or 35,000 members since 2018 when the reinsurance program started. And total enrollment in the individual market stands at 231,000 members. For the 3rd year in a row, we have asked carriers for detailed COVID data, asking them to give us, details divided by vaccinations and testing cost and hospitalization treatment cost, and broken between, ICUs and non-ICU utilization. And what we're seeing in the 2022 data is pretty much a return to normalcy, that, COVID greatly distorted the claims in 2020 and 2021. And into January 2022, there was definitely a big surge in COVID claims, but consistently across both the individual and small group markets, carriers are showing that throughout the rest of 2022, COVID claims have stabilized at a small percentage of total claims, and no carrier is projecting any meaningful, significant changes in COVID costs going forward. So, this will probably be last year we asked for that detailed COVID information, barring, another surge, that causes concern. A new issue this year, which we do not have a lot of data on yet, is the impact of the Medicaid disenrollees. The federal public health emergency ended, and nobody has been removed from Medicaid since COVID public health emergency began in 2020. And that changed. The first people in Maryland were removed in June. The Maryland Department of Health has a dashboard on their website, and they are tracking how many people have been removed. But projecting how many of those people who have lost coverage will move into QHPs, and projecting the relative morbidity of those members compared to the existing individual market are both things that you know, that there is very little data right now, and there is conflicting data as far as morbidity. Some studies suggest that this population is slightly healthier. Some suggest it is slightly sicker than the individual market. And so at this point, no carrier is making any explicit adjustments, but that might change between now and approval, as carriers and us are monitoring the number of people being disenrolled, and you know, as we are able to get any data on, you know, this movement. The disenrollments will be completed within 12 months. So this is a rate issue, you know, that is going to be unique for 2024. And you know, it is, you know, something we are focused on right now. Next slide, please. Just for some context, I wanted to just lay out where the Maryland rates are compared to the rest of the country. And this is from the Kaiser Family Foundation. These rates are for an age 40-year-old non-smoker. And they look at all of the state exchanges and pull the lowest average rate for each metal level, average across all zip codes in the state. So at the top, back in 2018, Maryland was slightly better than the US average. You know, on the bronze, the UHS average premium was $341, Maryland was $321. That was 6% lower than average. And similar stories on silver and gold. In 2023, after the reinsurance program has been working for 5 years, Maryland is now 29% below the national average. The national average is at 342, and Maryland is at 242 for bronze. And once again, it's similar for silver and gold. Silver, you know, we're a little worse. We're only 25% better than the national average. Gold, we're 32% better than the national average. And then comparing us to the absolute lowest state in the country, back in 2018, we were a pretty large margin above the cheapest state in the country. You know, 62% higher on bronze. You know, there was a state where you could get a bronze plan for less than $200 back in 2018, and we were already at $321 for that age 40-year-old. Fast forward to 2023, and Maryland is now the lowest state on bronze. It's the lowest state on gold, and it is 5% above the lowest state on silver. So, you know, this is the context of where these rate increases are being applied to. The reinsurance program has pushed the Maryland individual rates to, you know, amongst the very lowest in the nation, very far below the national average. And you know, this is an increase from that lower rate level that has been achieved by the reinsurance program. Next slide, please, Craig. So in the other markets, in the small group marketplace, the average requested renewal is 7.5% for all 4 quarters. As the commissioner said, there's a wide range by carrier. It ranges from a 1.4 to a 20.4%. While there is that wide range, 91% of the market are in carriers. They're asking for single-digit increases. That those significant double-digit increases are, you know, a handful of smaller carriers. And you know, we are looking closely at all of the filings, as we always do. But the, you know, the majority of the market is closer to that 7.5% average. Enrollment in the individual market has decreased by 4% in the last year, leaving the pool at slightly under 240,000 members. So, it's now only slightly larger than the individual pool at 231,000 members. Once again, this is lower than what was requested last year. Carriers initially asked for a 10% increase last year. We ended up approving a 7.6% increase. So this is in line with what was approved last year in the small group marketplace. And then in the individual dental ACA market, the average filed renewal is minus 1.3%, with the rate changes request ranging from minus 3.2 to plus 4.2, depending on the carrier. Enrollment in the dental product has grown by 1% over the last year. This follows multiple years of high double-digit growth, like the individual medical market. The total enrollment in these standalone dental products now stands at 96,000, or about 41% of the total individual market is choosing to purchase these. As a reminder, these plans can only be purchased by people who purchase an ACA medical plan. There are other dental products available off the exchange that can be purchased without, but these have to be purchased alongside a medical plan. Next slide, please. So I apologize if these numbers are a little small, but I wanted to put out some claims data to show what has been going on with the overall claims trends in the individual and small group marketplaces. This data comes from the Unified Rate Review template, which all carriers must submit with ACA rate filings. It's a standardized template, and we have aggregated all of the carriers in the individual and small group markets. This goes all the way back to 2014 when the ACA first started. And this shows year over year how the claims PMPM, the per member per month claims, has changed. Back in 2014, you can see the individual and small group markets were very close. Small group market had a $368 PMPM. Individual market was at $356. As a note, that was already a big change from pre-ACA. Pre-ACA, small group was already guaranteed issue, no medical underwriting, but individual was medically underwritten. So if you go back a year to pre-ACA, the individual rates would have been half of the small group rates. We don't have standardized templates though, so I can't show that here, but just for that context. But even in that first year of the ACA, the individual rates had already gone up to I keep saying rates. These are claims. These are not rates. These are the allowed claims PMPMs. This is the total claims for the members in these pools. So in 2014, the individual pool and the small group pool were approximately equal, but then you can see the small group pool increased by low single digits every year. Throughout the entire history of ACA, until you get to 2021, which is being distorted by COVID. 2020 and 2021 here need to be taken with a big grain of salt because of COVID. But small group has consistently had low single digit trends. But you can see in the individual market in those early years of ACA that the trends were double digit, significant double digit. I've got annualized averages on the very bottom. So for those first 4 years of ACA, small group was averaging a 3.3% year over year increase in claims, while the individual market was averaging an 11.6% increase a year. Since the reinsurance program was implemented, that has changed drastically in the individual market. And we've seen things come down, and it is now an annualized 3.1% change in the individual market. So there's been a definite inflection point in that trajectory of individual claims. So this is this shows that the reinsurance program is working above and beyond just taking claims out of the market and allowing the premiums to be cheaper. It's allowing that pool to stabilize and the morbidity to improve. In small group, over the last 4 years, we've seen the annualized increase a little bit to 4.6%. And we're trying to understand both why there is that bump up compared to where small group was the previous 4 years, and why small group is running higher than individual. And you know, the reinsurance program can certainly be part of that. And you know, impacting all of this is just putting these claims changes in context with inflation. You know, inflation affects all sectors of the economy. From 2014 to 2018, inflation rates in the United States were extremely low. It was an average of 1.4%. But from the last 4 years, as everybody knows, after COVID, inflation has skyrocketed, and the general inflation is averaging 4.1%. So, you know, in terms of how far above inflation these trends are, you know, the trends are actually, you know, better related to overall inflation. And so that could be some of this driver that we're seeing, but this is the overall, you know, large picture pattern of what's been going on in these two markets. And you know, I'll also note that, you know, the individual claims are still significantly above the small group claims, you know, even though the trajectory has changed, you know, the claims levels have not yet equalized. And, you know, as of 2022, you know, you've still got a claims level that's 24% higher in the individual market. And so, you know, that's why the reinsurance program is still needed, even though this market is stabilized. It's stabilized at a very high claims level relative to all the group markets. Next slide, please, Craig. This is a snapshot of the risk adjustment transfers in Maryland. This is for 2022. These are the actual numbers that were just finalized by CMS on June 30th. And I just wanted to show these for, you know, the context of the size of these transfers between different carriers. On this chart, any number that is negative in parentheses is a carrier that is paying into the risk adjustment program. And any number that does not have parentheses around it is a carrier that is receiving money from the risk adjustment program. And you can see in both the individual market and the small group market, you know, CFMI and GHMSI, the two CareFirst PPO entities, are getting significant risk adjustment payments, and almost all of the other carriers in the market, who are primarily HMOs, are paying into the risk adjustment program. And I just want to stress that, you know, this is an annual part of what we review in these carrier rate filings for the ACA, and it is a very challenging assumption for all of us. You know, traditionally on every other type of filing and for every other aspect of the ACA filing, a carrier is trying to project their own claims data with, you know, the benefit of having lots of detailed information and data about their population. But for risk adjustment, a carrier must both project their own level of risk and the risk level of the rest of the marketplace. And that second factor is what makes it very challenging. So even if a carrier perfectly predicts its own claims level, you know, there's still a risk on this, you know, risk adjustment transfer assumption, and carriers need to make sure that they are building in enough, you know, to pay whatever risk adjustment payments that they have to pay in. And so, you know, I will say that carriers in general have all gotten better at predicting these as the years have gone on, with the benefit of experience. But it is one of the inherently, you know, more uncertain assumptions in these ACA rate filings. And you know, in general, the smaller the carrier is as far as market share, the more uncertainty there is in this assumption, because the more they can vary from the market average. Next slide, please. So this is the contact information for both myself and for Craig. as a reminder, all of the rate filing documents are already posted on our website. The URL is here. You can view the actual memorandum. You can view that unified rate review template that I was talking about. There's a consumer-friendly summary that is viewable. And you can also submit comments directly through that website for any filing that you are viewing. Comments are being accepted through August 11th. And so please, if anybody has anything that they'd like to submit, please, either contact Craig or I, or submit it through our website. And then I have a couple pages of appendices, Craig, but yeah, I guess we'll walk through these. I mean, this just shows the detail by carrier of what everybody's asking for. So, the 5.7% average in the individual market is, the Care First HMO is asking for 6.4%. The Care First PPO is asking for a 0.5%. Kaiser is asking for 8%. United Optimum Choice is asking for -2%, and Aetna is new. So there's no rate increase, but it will be a new option. And then the next tab, please. This is all the details for the small group increase requests. I'm not going to walk through every one of these. This shows the quarterly renewals because unlike the individual market, carriers pre-file quarterly adjustments to their rates. So the renewal increase in each quarter is slightly different. And then, like I said, you can see that by carrier, the carriers with the very large increases have pretty small market shares. And then if you could just go to the last page quickly, and then this is the breakdown by dental carrier. Alpha Dental is the carrier asking for the 4.2% increase, and then all of the other carriers are asking for the decreases. So that's everything I had. Thank you.
Thank you very much, Brad. I appreciate that. Those slides, as I indicated, will be on our website. And if folks have questions, they are welcome to submit that, to that same address. And, we'll do our best to try to make sure that people get whatever additional information is helpful to them as we go through this process. And one of the things that I want everyone on the call to understand is where we start is not where we end. So we go through a very detailed, rigorous process. And at least since I've been here, I haven't experienced a circumstance where our actuaries approved what was originally requested. So, we haven't prejudged anything this year, but I would expect that things hold as usual. That will happen this year as well. So with that, I think we'll turn now to the insurers that have filed rates in our markets for this year, and we're just going to go through them in alphabetical order. We'll start with Aetna, and I believe we have Mr. Schneider, who's the Executive Director of Actuarial for Aetna. Mr. Schneider, welcome. We're happy to hear from you today.
Yes, hi. Can everybody hear me? Is it all working okay?
Yes, working fine. Thank you.
Okay, thanks. So good morning, everyone. So thanks for the opportunity to present our some information on our 2024 ACA rates. Aetna is working really hard to make healthcare simpler, easier, and more convenient for the people of Maryland. And as I think Brad and others have noted, next year, in addition to our current small group presence, which has been there for a while, we're entering the individual market. So we're excited about that, to expand our presence in Maryland. Our individual plans, they use the scope of Aetna and CVS Health, our parent company, which includes health insurance, pharmacy benefits, retail-based health services, mental well-being programs, telehealth, digital, and more, to provide greater value to individual consumers. We're offering 9 individual plans on exchange through our HMO entity, Aetna Health Incorporated. In the small group market, we file rates for 2 legal entities, the HMO entity, Aetna Health Incorporated, and the PPO entity, which is Aetna Life Insurance Company. And we have about 7,500 individuals in Maryland that are covered under our small group policies as of May. So I want to start by noting all the changes that I'm going to be discussing in the numbers. The changes are their averages. So the exact rate change for someone is going to depend on a bunch of other factors like the benefit design, employer and employee characteristics, and also, since we're just entering the individual market, anything about rate changes and the numbers will relate to the small group entities. The process for the individual is essentially the same, although all the numbers that I'm going to talk about will as I describe it, will relate to the small group since there's no change for individual. So there are four main drivers for the rate changes that we filed. The first is medical costs, which are always rising, unfortunately. The plan design changes, the estimates of the morbidity in the small group risk pool, and I guess similarly for individual for those rates. And then other items such as experience being a little bit different than we expected when we last set the rates. So I'll discuss each of those in a little bit of detail shortly. For HMO, the average increase is 15.3%. For PPO, it's 1.5%, and that averages to about 12.2% since most of the business is in the HMO. We filed 12 HMO plans and 21 PPO. 3 of each are offered both on and off exchange, and the remaining 9 HMO and 18 PPO are offered only off exchange. So as I mentioned, these are weighted average rates. So the exact rate will differ based on a number of factors, and it also will differ by quarter. So the first quarter increase will be a little bit higher. They'll get lower as the year goes on, since our trend is a little bit lower. So I'll now review these main drivers in a little more detail. The medical costs, both medical and pharmacy costs increase for 2 reasons. The first is that providers are raising their prices each year, and the second is members get more medical care as time goes on. The projected trend combining all of those is 8.7% for medical, and for prescription drugs it's 4.1%, and that averages to 7.8%. The plan design changes, which include changes to the benefits within a plan, but also when we switch plans, we will end up mapping people to other plans, and that on average increases the costs by about 2.4% for HMO, 2.2% for PPO, and that combines to about 2.3% increase. The morbidity in the small group pool, which is a meaningful factor, our estimate of the average population health and the expected risk adjustment transfers, it changes, and it has changed this year to reflect new data that we have on average premiums and the population health. Small groups purchasing insurance in the marketplace are healthier for us than we initially anticipated, and these differences are expected to decrease our costs by about 9%. And I want to add something there that was sort of prompted by some of the comments Brad made on risk adjustment. The important thing to remember is that that 9% doesn't necessarily get reflected in the rates, because that also means we're paying more into the risk adjustment. And as Brad said, that has to be kind of looked at together and complicates things. But we are seeing the population as healthier than we initially anticipated, or projecting it at any rate. The other items that we have contribute to about 4.4% increase, and these include most prominently claims experience that came out a little differently than we expected. And this is in 22. And another comment on a point Brad made, which is that the year before that obviously was 21, and then before that was 20, and those are the years that were really difficult to project. So those made it difficult to project the 22 claims, and as I said, the actual cost did come in a little bit higher than we had projected. So I think that kind of concludes my specific comments on our rate increase, but we also want to update on some of the things Aetna is doing to try to keep premiums affordable, which we'll try to reflect in our pricings. And we're taking a number of steps to do that, including new agreements and arrangements and partnerships with the providers that base compensation on quality and not just the quantity of services provided. We're trying to create medical management programs that address health issues earlier, improving the health outcomes and reduce the need for higher cost services later. And last but not least, working to reduce the ability of out-of-network providers to collect unreasonably excessive payments for services they provide. And all of those things are significant efforts to try to curtail the increases in costs. So I think with that, I'll conclude, and I'm open to any questions, but thanks for the opportunity to present our rates to you today.
Thanks. Brad and Adam, do you have questions? Or Henry?
Sorry, I had to unmute myself. I have just one question. So you stated that part of the driver is the 2022 claims came in higher than expected, but my records say that on the HMO entity that's getting the 15.4 now, that in 2022 you had filed for a significant downward rate correction, a minus 26.8%. And so while they did come in higher than expected, I just wanted to clarify that the overall expectations were a decrease, that there had been
That's right.
that correction made. So I've got that, even with this 15.4%, that the rates that you're asking for are still lower than the 2022 rate level. And so I just wanted to make sure that was accurate.
Yeah, that's a good point. Last year, or for this year, I should say 23, it's a fairly modest increase, but we did lower them significantly for 22, and it appears we lowered them a little more than we should have, is what our take is.
All right. Thanks for that clarification. And in the individual market, I am correct that it's going to be available in all counties, correct?
I believe so, yes.
All right, wonderful. And I think that's the only questions I had. Thanks for your presentation.
Okay, thank you.
Adam or Henry, did you have any questions?
I do not.
Okay, thank you.
Mhm.
And let me just make it very clear to the attendees that we go through a very detailed iterative process, with the carriers as the filings come in, and there is a process of interrogatories and questions that are asked. And so that is a process that has been well underway since May. So the fact that there are not any questions today doesn't mean, as all of the carriers will tell you, that they are not already been peppered by hundreds of questions, including looking for the detail. Brad is smiling because he knows he's the author of many of those questions, that gets into the details, particularly details on claim trends and information. So I don't want anybody to feel that the fact that you're only hearing a couple of refining questions today doesn't mean that there hasn't already been a pretty rigorous process so far. So with that, Mr. Schneider, thank you for the information that you've provided to us today. And we will now move on to Peter Barry, who is the Chief Actuary, Senior Vice President of Actuarial and Underwriting at CareFirst Blue Cross Blue Shield. Mr. Barry, we're happy to hear from you about CareFirst's rate filings in the individual and small group markets.
Thank you very much, Commissioner. Good morning, everyone. As Commissioner said, I'm Pete Barry, Chief Actuary for CareFirst. I'll be speaking to the 2024 ACA rate filings for individual and small group. CareFirst participates in both segments, and we offer HMO and PPO products in both segments. So I'm going to start with individual HMO. As Brad said, we have filed a 6.4% rate increase, which is mid-single digit, consistent with what we filed last year. The key driver of that increase is morbidity. What we're seeing is a relatively high morbidity for new entrants to CareFirst this year, but we're continuing to look at that. With regards to trend, it remains fairly moderate. But one thing that we are concerned about and looking at, which Brad also mentioned, is the drop in COVID care in 22 versus 21 is substantially leveraging down our observed trend. So we just want to make sure that we're taking that into account as we forecast it forward. And I'll talk a little bit more about trend when I get to small group and address the issue of small group trends versus individual trends. It's still very early, like Brad said, on redetermination. We are an MCO in the Medicaid market, but we have very small market share, so we don't have too much intelligence. But looking back, we see that most of the Medicaid members dropping out historically have gone to the group market, not the individual market. As Brad also said, there's not much data yet, and we're not seeing too much data, so we have not made any explicit assumptions for redetermination, but it's something that we are watching very, very closely. For our PPO, we have asked for a 0.5% increase. That is very moderate compared to last year, but we have to realize that the PPO block we have is relatively small and very volatile. These are very sick members. They get a lot of reinsurance, and so the rate change gets massively leveraged by the reinsurance assumption, so it can move around quite a bit. But what we've filed for now, and we're continuing to work with Brad's team, is the 0.5. And we're also seeing moderate trends there. Any questions on individual, or do you want me to move on to small group and take them all at the end?
That's up to you, Brad and Adam and Henry, how you want to address it.
I'd say we'll just do all the questions at the end. Just go
Sure,
ahead.
sure, absolutely. So moving on to small group Blue Choice, we filed a 7.9%. Again, that is substantially lower than the double-digit increase we had requested last year. So we're very glad to see that. In this case, the increase is driven by the base period claims increases, as well as an accelerating trend, and I'm going to talk about that in a little bit. Our current file trend is consistent with prior filings. It's slightly higher than last year's, but it's slightly lower than 2 years ago. And what we have seen, as Brad mentioned, was for the last couple of years after the care came back in 2020, that our small group trends were actually higher than our individual trends. And consistent with what Brad also said, the trends are higher, but the PMPMs for individual are about 20 to 25% higher for small group, so it doesn't indicate higher costs. We do see some categories though where that is the case, like emergency room, and so it's something we're paying attention to. But as we look at the trends for small group, we started seeing them accelerate sometime in 2021 into the fourth quarter, and I know that triggered a lot of quarterly filings for folks. And those higher trends continued into the first part of 22, and then they began to narrow some. And so through the end of 22, small group was still higher than individual. An early look at 23 is that may have turned, and as individual heats up going into 2023. So again, that's something we're watching very closely. We're still trying to understand those drivers, and so we'll be working with Brad's team over the next month or so to try to tease that out. Moving on to small group PPO, increase of 6.2. Really, that's driven by the base period increasing by about that much. We do see a slight deterioration in morbidity from the prior year. What we saw a dynamic in 2022 where we had a slightly healthier population than we had in 21. It looked like some sick people dropped out. I don't know if that was morbidity or mortality or economics, but what we're seeing now in 23 is that morbidity is returning to the pre-2022 levels. And so that's a slight 1 to 2% upward pressure on the rates. So that is my comments. I'd be happy to take any questions.
Brad, Adam, or Henry?
Thanks for the information. So as far as those higher small group trends, you haven't really been able to identify a particular driver yet internally, if there's any particular service category or type of service that it's really pushing that?
Yeah, I do have a little bit on that. We're continuing to look at it, but I could tell you that for inpatient, one of the dynamics we saw during the pandemic was a move from inpatient to outpatient care generally. And so what we see in the individual market is negative trends for inpatient, whereas the small group trends are actually flat, which surprised us. And then on outpatient facility, we're seeing a substantially higher small group trend than individual. Largely, what we've seen generally on the outpatient is it's driven by surgeries. And I don't know if the other carriers are seeing this, but we're seeing a lot of hips and knees done in an outpatient setting now versus an inpatient setting pre-pandemic.
All right, thanks for that information. And then in both market segments, specialty drugs continues to be a driver on the drug side, right? There wouldn't really be a big difference in small group.
Yeah, we can look at that. Absolutely. Specialty drug is the key driver on all drug costs. And generally speaking, drug trends are higher than medical trends and driving the trend higher. And we are seeing that. And we see some of the, we're starting to see some of these gene therapies show up in some of our experience. And so we're having to take that into account as well.
All right, thanks. Adam or Henry, do you have any questions?
I think I'm okay.
All right, thanks very much, Pete.
Good. Thank you very much for the opportunity. I appreciate it.
Thank you, Mr. Barry. Next, we will hear from Stephen Chong. I want to make sure that I pronounced your name correctly. I apologize if I did not. Who is an actuarial associate with Kaiser Permanente.
Yeah, thank you, Commissioner. It's pronounced Stephen Chuang, so that was good. And as you said, I'm actuarial associate at Kaiser and also the certifying actuary for our Maryland ACA filings. So I'll be speaking on both of those today. So I'll begin with our individual filing first. This rate filing represents 19 plans offered both on and off exchange. Several plans received minor changes to keep plans within the appropriate actual value range. The biggest change to our individual portfolio for this 2024 filing would be the addition of the standard value plans. We added these value plans to the gold, silver, and bronze tiers. 2 plans were removed from the portfolio to make space for the new value plans, and 1 existing bronze plan was converted to the bronze value plan. We also added a new gold plus plan to the off exchange only. These plans currently service approximately 61,000 members throughout Maryland, which is around the same as our 2022 average and an increase compared to 2021 with 58,000. Membership for 2024 has been projected to decrease slightly. For next year, we have filed for an average rate increase of 8%, though depending on the exact plan, rate changes may vary from a 5.6% increase up to an 11.3% increase. Some of the main drivers for the rate increase would be base period allowed claims, trend, and risk adjustment. The rate increase produces a projected MLR of 95.7%. The state-based reinsurance program has had significant impact on our rates. Without this program, our estimate is that the 2024 rates would need to be 30 to 40% higher than filed. Next, I'll talk about our small group filing. For the small group market, our filing represents 60 plans, including both on and off exchange and 2 different provider networks. These plans currently service approximately 9,600 members throughout Maryland, which is lower than the 10,000 in 2022 and 10,400 in 2021. Our 2024 projected enrollment is also expected to drop slightly. We have filed for an average rate increase of 9.2% for 2024. The rate changes vary from 6.7% to 12.4%, and that depends on the plan and also when the group renews. The main drivers of this rate increase are trend, risk adjustment, and our retention. The rate increase produces a projected MLR of 94.1%. Our annual trend is higher this year compared to previous years, and this is mostly based on budgeted fixed costs. We experienced a higher number of care delivery retirements during the pandemic than expected, which resulted in suppressed internal costs. We are forecasting a ramp up in care delivery staff back to pre-COVID levels during 2023 and 2024. And this increase in internal costs is driving higher trends than in the last couple of years. Regarding COVID in 2022, claims related to COVID dropped to 1.5% of our total claims in Maryland, and this compared to 5% in 2021. So no adjustments were made to account for expected changes in COVID-related costs. We assume COVID is here to stay, and there will be some costs in 2024, but that they will remain low throughout the year. Medicaid redetermination was also considered in the current projections. Based on the market information that was available to us, our membership forecasting team did project an expected reduction in members from the Medicaid line of business, and a portion of these members are expected to be captured within our various lines of businesses, mostly allocated to the individual ACA. For now, we estimate additional individual members for 2023 with a distribution of members between gold and silver plans. This also flows through to 2024 membership projections, but it'd be difficult to be precise at this time due to auto assignments being dependent on rate positions. So as Brad said, we didn't really make any explicit assumptions around this. That concludes my comments. And are there any questions for me?
Thank you. I just had one clarifying question. You talked about the driver of high trend being, budgeted fixed cost. Could you just briefly explain the difference between your staff model HMO versus a traditional fee for service HMO?
Yeah, certainly. So Kaiser, we're integrated carrier, so that means we have our own medical facilities. That means our internal fixed costs will look different compared to traditional carriers. That means depending on our care delivery model, the amount of staff that we have and doctors, that all flows through to our internal costs. So our trend model will look pretty differently depending on, as I mentioned earlier, our staff levels and other fixed costs.
Thanks. So yeah, the difference is that your costs are the direct salaries of those you employ that are then allocated as claims versus fee for service. And so thanks for that clarification. I think that's the only question I had. I think we'll continue to correspond about the Medicaid redeterminations and any information any of us can glean as the next couple months go on. But I don't have any other questions. Adam or Henry, did you have anything? All right, thank you, everyone.
Thank you, guys.
Thank you.
So I think everybody needs to be on. Mute. Oh, I'm echoing.
Mr. Morgan, I think your sound may be a little high still.
Okay, let me take that down.
Thank you.
Is that better?
What I'm going to do is introduce you. Can you go on mute until I introduce you?
Sure.
Thank you. Okay, so we're getting an echo from you every time. I don't know why that is, but every time that somebody else is speaking, it's helpful if you're on mute. And I know that's annoying to go back and forth, but I think that'll help us all. So I'm introducing Mr. Ryan Morgan, who's the Director of Actuarial Services at United Healthcare. Is Catherine with you today? Yes.
Yes, thanks so much. Good morning. Thank you, Commissioner Bahrain and the MIA for the opportunity to present today. I'm an actuary with United Healthcare, and I'm here to discuss our 2024 small group and individual rates that we filed. So we'll start with small group first. United Healthcare continues to offer small group policies on 4 legal entities: United Healthcare Insurance Company, Mamsie Life and Health, Optimum Choice Incorporated, and United Healthcare of the Mid-Atlantic Incorporated. Across all 4 of these legal entities, we are proposing a total of 118 unique small group plans in 2024. That breaks down as 16 platinum, 57 gold, 41 silver, and 4 bronze. And about 20% of these plans are available both on and off exchange, and the rest are available off exchange only. So in the small group market, in the filings we sent back in May, we requested the following increases: 11.5% for United Healthcare, 6.9% for Mamsie Life and Health, 4.6% for Optimum Choice, and 20.6% for United Healthcare of the Mid-Atlantic. And let me be clear, those figures represent an average change for each entity. So obviously any individual group could have a higher or lower increase depending on a variety of factors. So one of the primary drivers was just our trend rate. As we always do, United conducted a full review of the components that contribute to trend. Using the most recent information available, we analyzed unit costs, utilization, deductible leveraging, other factors, and all these were looked at separately for inpatient, outpatient, professional, pharmacy, and other services. So based on that analysis, we filed for a trend rate of 9.4%, which was reflected in our filing. Turning to individual, United Healthcare continues to offer policies on the individual exchange after re-entering the market in 2021. We're selling plans statewide under the Optimum Choice license and offering 12 individual HMO plans in 2024. Those break down as 4 gold, 4 silver, and 4 bronze, plus all the associated cost sharing reduction silver variants. As mentioned earlier, we submitted our 24 filing with an average premium rate decrease of 2% for individual block of business. But again, this is an average and will vary based on individual plan selected. And the primary drivers on the individual side, changes in experience, the application of additional year of trend, and changes in the expected demographic and metal mix of the population. And then also we project that changes in morbidity due to Medicaid eligibility redeterminations will not make a material impact on rates for 2024, as others have stated. So hopefully the summary of United Healthcare's 2024 small group and individual filings has been helpful. At this time, I'd be happy to address any questions about our small group rate filings. We also have Catherine Simon on the line from UHC, who is available to answer any questions about individual rates. Thank you.
Thank you. I had a question about the small group filings. I was wondering if you could provide any insight as to the divergence in rate requests between the two HMO entities. In past years, the rate increases have not been identical between the two HMO entities, but they have been much more similar than this year. And we're trying to understand the driver of that different experience in the two segments.
Yeah, that's a good question, because I think like going way back into the past, we used to pool them all together and kind of just keep the same differences. So yeah, I think honestly, some of the entities have shrunk, so there's probably a little bit less credibility. So just when you look at each entity separately now, there's a little just more natural variance from that. I think we have also seen kind of just a divergence in kind of risk adjustment as well, especially for some of the smaller entities. That's maybe gone a little bit differently than expected as well. I guess I will say on that, the entity with the highest increase, the 20, the one that was over 20, now we did actually just see in this most recent official CMS update a little bit of favorability there. So I think that's down to like 16. So that did kind of converge them at least a little bit. So they're not quite so far apart.
All right, that's good to hear. And I mean, if there's not an objection yet, it should be soon to ask you to update for the risk adjustment actuals. So it's good to know that that's going to help that 20.4%. That's the only questions I had. Henry or Adam, anything from you?
I'm good too. Thanks.
Thanks so much.
Thank you very much as well. So now for the next part of today's hearing, we are going to hear from the two individuals who signed up to comment on this year's rate filings. First, we'll hear from Stephanie Clapper, who is the Deputy Director of Maryland Healthcare for All. Ms. Clapper, happy to hear from you today. Thanks for joining us.
Thank you, Commissioner. Thank you for the opportunity. I'm from Maryland Citizens Health Initiative, and we are a consumer advocacy organization. We advocate for quality, affordable health care for all Marylanders. And in considering the proposed rates, we encourage the Maryland Insurance Administration to continue to make protecting consumers and reducing the high cost of premiums its top priorities. We especially thank you for your leadership on the state reinsurance work group. And we are wanting to just express our appreciation for the reinsurance program and its success in stabilizing rates in Maryland, as well as the success of the Young Adult Subsidies Program, which is encouraging young and healthy adults into the marketplace and also helping to stabilize premiums. In thinking about rates, we want to highlight that no examination of affordability in the individual market would be complete without looking at skyrocketing drug costs, and that we in Maryland are fortunate to have the first in the nation prescription drug affordability board. That board is nearly ready to release its plan to set up our payment limits for state and local governments. And we want to go a step further, and we support the board gaining the authority to go beyond this, to expand its authority to set up our payment limits for high cost drugs for all Marylanders, which we believe would further help to stabilize rates. So with that, thank you again for this opportunity to comment and for doing everything in your power to helping ensure quality, affordable health care for all Marylanders.
Well, thank you very much. And, you know, that the bulk of that good work is done by Brad and Adam and Henry and the members of their team, and as well as our colleagues at the Maryland Health Benefit Exchange. So we particularly want to recognize them and their good work with respect to the reinsurance program. Next, we have Brett McCone, who is the Senior Vice President for the Maryland Hospital Association. Mr. McCone, it's nice to see you today. Thanks for joining us.
Thank you, Commissioner Borrain. Good morning, everyone. As Commissioner Borrain said, I'm Brett McCone, Senior Vice President of Healthcare Payment for the Maryland Hospital Association, and appreciate the opportunity to speak with you today. Though we'll be more specific in our final August comment letter, our messages today are pretty simple. I think from a what is a justification, particularly for the hospital piece, of seeking any amount above what the Health Services Cost Review Commission, or HSCRC, approves? And I think there are a number of different questions here. While we certainly appreciate that we've seen recent changes in premiums that have been filed come down from what was originally filed, or come down overall since 2018, I think an important question is how much of this is due to just our rate setting system in general, the fact that there is no cost shifting in Maryland, and that all payers, including governmental payers, pick up their fair share, which is much, much different than it is in the rest of the country. And I appreciated Mr. Bobin's slide earlier showing Maryland's premiums relative to the nation, and the fact that we are 25 to 35% below the nation. I think an important question to ask there is, how much of that is due to the reinsurance program relative to at least what we've done in the hospital space. As we've shared in the past, hospital revenue in the state in aggregate and at each hospital is fixed for both price and utilization. So the insurance carriers typically weigh in to the appropriateness of that amount at the HSCRC public meeting. And of course, then these amounts are known, July 1 amounts are known in advance of these rate filing decisions. Our ask is simply that for any carriers exceeding these amounts, as we look at this as the MAA looks at this over the next month or so, let's understand, why that hospital trend is different than what the HSCRC approves. We've heard a lot of talk about trend today. And I would say it this way, to be simple from the hospital field's perspective. I spent the last 4 or 5 months talking with the HSCRC about true inflation trend, about what hospitals are facing to go into to that cost growth. And essentially, as we talked about that, they said, this is important, and we do see that there are substantial labor pressures on hospitals, but unfortunately, we are limited by what we can do on our overall model. So, that limited what the hospital revenue growth can be, again, for both price and utilization. So when we talk about actual trend that the insurers are experiencing, we certainly are at risk under this model for both price and service growth. And I think additional transparency around how that relates to the carrier spending would be important. I think prior 2014, spending on hospital services was divided into those two components, to both price, which was known and fixed by the HSCRC and had been since the 1970s, and service utilization, which wasn't predictable. Yet in a fee-for-service system, prior to 2014, we saw hospital costs growing very rapidly and steadily. It's not predictable. We have seen that limit on utilization, and recent analyses of national health expenditure data show Maryland's both hospital and total spending per capita to be well below the national trend. And this has occurred for the last several years. And so I think understanding how, the healthcare premiums, the insurance premiums relate to that is critical, particularly understanding what the impact of the reinsurance. I believe it was Mr. Schweng from Kaiser that said without the reinsurance premiums, their rates would need to be 30 to 40% higher. So that's a critical, thought there. Again, our question is, if that is the effect of the insurance premium, then what is the effect of rate setting here in Maryland, in particular, the controls on both hospital prices and use, as well as the fact that we don't see, the big subsidies that we see in other states where commercial insurers are paying 140 to 150% of hospital costs to make up for much lower Medicare, Medicaid, and uncompensated care payments. So again, I think we certainly appreciate that. I think better understanding of that. I think more transparency in risk-based capital would also be appropriate. Again, we've just gone through this conversation where, from a hospital perspective, have been challenged about, what is the appropriate financial condition for hospitals and what is our appropriate measures. I was actually asked that directly by one of the commissioners on the HSCRC who works for one of the carriers. And I'm curious as to the same question here about risk-based capital ratios, balance sheets, margins, and other things, given the conversation that is happening on the hospital side and the financial devastation we've seen over the last 6 months. We do appreciate the need to keep healthcare affordable. That goes with out-of-pocket, consumer cost sharing as well. I think the model does that. Maryland's unique total cost of care model does that by certainly holding down both hospital and total spending. We appreciate that, this savings will be passed on and should be passed on to consumers, and appreciate your time today, and happy to answer any questions that you may have.
No, I appreciate that. And I appreciate your comments. Many of those comments are, much broader than the approval process for rates, right? And some of them, I think, are comments that we may want to take more into consideration with respect to the House Bill 413 working group and those hearings regarding the reinsurance program and other market reforms and the impacts that they're having and how, what additional adjustments may be appropriate or needed. So I would invite you to participate in those working groups as well. Obviously from a solvency perspective, insurance companies have a fairly detailed and fairly elaborate oversight process as it relates to their risk-based capital. All of that is in statute. And I have a financial regulation team that is dedicated to, that review and that analysis. And part of what they do is address the RBC formulas, RBC of companies, make sure that they fall within the parameters they're required to fall within. Part of our surveillance is watching that trend. And also in statute in Maryland, with respect to nonprofit health plans, CareFirst of which is the largest, have a set of special requirements and a review of their surplus and their RBC in a much more detailed, and careful way. And those are all background considerations, if you will, when we look at rate filings and we look at the numbers that carriers have proposed, including things like their contribution to reserves. So I can assure you that there's a very holistic view at with Brad's group as they look at rates. And I can also assure you that, you know, our team, the large reason why our financial regulation team exists is to assure that companies are solvent and healthy, but also to make sure that those numbers are within a reasonable range, right? Because otherwise, you know, they do have the potential to impact rates in potentially inappropriate way. So just a few comments in response to some of the things that you've said, but your remarks are very much appreciated. I don't know, Brad, if you had any comments that you wanted to make, or we can also have, you know, part of this conversation offline once we get your written comments.
Yeah, I mean, I'll just add that, you know, we definitely monitor the HSCRC and their update factor, and we definitely do incorporate it in our analysis and use it to analyze the reasonableness of trend assumptions. You know, on a high level, the major driver of trends are unfortunately the service categories that HSCRC does not control. Specialty drugs, which has already been mentioned, and professional costs generally have the highest trend components, you know, market wide. And you know, yes, there are some carriers where there might be an exception, but you know, we look, you know, at the service category level detail consistently year after year, and you know, we are taking this into account. But you know, I understood the desire for more transparency and to make sure that there is consistency with, you know, the hospital rate setting and what's flowing through to rates, and you know, we will endeavor to do that.
Thank you, Mr. Rowan. I appreciate that. And we certainly, you know, understand that you do that, and that hospital rates are only one component of that, and it can appreciate. And we've had that conversation with carriers too about the, you know, the rising, you know, the commercial drug prices and other things. We understand that. Our main focus is around, you know, the hospital component to make sure that at least that input, you know, mirrors what we're seeing, and understanding that, you know, what we're facing as well. And again, I just encourage more transparency in that, particularly on the consumer cost sharing piece too. As we all know, that's been a very hot topic in Annapolis recently, where as we continue to see, you know, bigger shifts to high deductible plans, and as we've seen that, you know, as one of the trends, unfortunately, the hospitals ultimately, we wind up working very hard and spending hundreds of millions of dollars to try and deal with that, and wind up having to be the ones to, you know, collect that, which is, you know, the contract between the consumer and the insurer. And so the fact that, you know, that has completely expanded in the last probably, you know, 5 to 6 years, and are now being held accountable for that, to say, well, hey, you know, this is just we're not a party to that contract, but yet this is, you know, the you know, the out-of-pocket responsibility. So I think all of those things fit together in our comments. Appreciate that.
No, I think that's helpful, and it's good to know. And, you know, the private insurance market does pick up a slightly larger percentage, you know, of the hospital care because it's allocated differently based on payers. But Brad and his team are on top of it. In your letter, you might want to detail what you mean by transparency, and like for that component of it, because I think we're fairly transparent in that aspect of it. But, you know, that doesn't mean that there isn't something that we're missing. To the extent that we can share information, because not all information that we get from carriers is shareable in the same way. And then the second thing I would just say again is I would invite you to participate in the public meetings on House Bill 413. Our next one is early in August. All the information is on our website. One of the things that we are specifically addressing is, as we look at market reforms and where kind of dollars go to, you know, improve, continue to drive down the uninsured population and keep people engaged and insured, that they can see the value in their insurance product and they're using it. One of the issues is whether is putting money into keeping deductibles down and reducing cost sharing. And that is I think an important part of the discussion that we're having with regard to the reinsurance report that's due to the General Assembly in December of this year. So I would invite you to come to those meetings and have those discussions. in that setting, which is probably the best setting for those issues and what product design looks like and how to get that consumer piece down so that people feel that they can access their insurance in a valuable way right away. So with that, we still have lots of time left on our agenda. So if there are any individuals, and I don't see any in chat, but if there are any individuals who did not have the opportunity to sign up, but who would like to comment, if you will type your name and your affiliation into the chat, we will be happy to invite you, bring you over into the speakers group and hear what you have to say. And I'm going to give folks a minute. Like, I'm not seeing anybody, but sometimes my old eyes are not good.
Yes, I'm not seeing anyone other.
Okay. All right, well, if you are having challenges or you otherwise don't want to speak at this point in time, please remember that we will accept comments from folks. That there'll be a slide that Greg puts up now that gives you information about where you can submit your comments, and also that provides information about where you can access a copy of this presentation.
So I'll have that up momentarily.
Thanks. So as you can see, this is the best place to access. In order to submit your comments, we would ask you to have them to us by Friday, August 11th. So that we have time to consider them as we move forward with our rate decisions. Okay, and with that, seeing no one else that's asked to speak, I'm going to close the hearing. So I thank everybody for your participation. As I mentioned, the hearing and all the materials submitted will be available on the MIA's website. That's how you can access it. You have the contact information for Mr. I and the contact information for Mr. Boban in case you have any follow-up questions and you know how to submit your comments. So thank you very much, and I appreciate everybody's participation today, and I'm happy to give you just over 2 hours of your life back. So thank you, and you can end the recording, Craig.